Good morning. My name is Sajada Outen. I'm a public health analyst within the Division of Healthcare Quality Promotion.
And good morning. My name is Paul Malpedi, and I'm an epidemiologist in the CDC Division of Healthcare Quality Promotion.
Welcome to the informational call regarding the new funding opportunity, CDC-RFA CK21-2104. Global Healthcare Detection and Response within CDC's National Center for Emerging and Zoonotic Infectious Diseases, also known as NCE-ZID. Thank you for taking the time today to be on the call. This meeting is being recorded and a transcript will be posted on grants.gov for your reference. If you do not agree to participate in the recorded session, please disconnect at this time and refer to grants.gov for the written responses to all questions. We ask that all participants turn off their video if it's on. All participants are muted, and if you have questions during the presentation, please enter them in the chat section or hold them until we open the line. We will take all the questions and provide answers in a document that we will post to the grants.gov website under the related documents section of the opportunity announcement. If you have not already done so, please go to the grants.gov site and activate the receive updates option so that you will receive all of the updates to the announcements. Today, we will provide a general overview of the funding opportunity, briefly review the components, strategies, and draw your attention to some key pieces of information. We will also provide a description of the application review process. Ms. Nicole Comic, the Grants Management Specialist within the Office of Grant Services, will discuss the eligibility requirements. Next slide. Please note that all requirements are stated in the published Notice of Funding Opportunity, which is CDC-RFA CK21-2104, titled Global Healthcare Detection and Response. This funding opportunity is published by the Division of Healthcare Quality Promotion within the Department of Health and Human Services, Centers for Disease Control and Prevention, National Center for Emerging and Zoonotic Infectious Diseases. The purpose of this funding opportunity is to enhance detection and response to infectious disease threats in healthcare facilities globally by developing networks to implement prevention and containment strategies at local, national, and regional levels. To develop and implement interventions to prevent, detect, and respond to infectious disease threats in healthcare, including AMR, HAIs, and COVID-19. To improve detection of emerging AMR and identify AMR risk factors and prevention strategies across the One Health spectrum, including healthcare, the community, and the environment to inform global AMR response and containment efforts. To provide flexibility to administer assistance during a declared public health emergency. Next slide. This opportunity is organized to support activities outside the United States in 3 distinct components. Component 1, detect and respond to infectious disease threats in healthcare facilities. Component 2, improve capacity to detect and monitor emerging antimicrobial resistance. Component 3, rapid response to infectious disease outbreaks or other public health emergencies in healthcare facilities. All applicants must apply for either component 1, detect and respond to infectious disease threats in healthcare facilities, or component 2, improve capacity to detect and monitor emerging antimicrobial resistance. Component 3 is optional, and applicants can choose to submit a work plan and budget for the optional component if they would like to be considered for funding at any time during the 5-year project period. Applicants must submit a separate budget and work plan for all components they would like to be considered for during the 5-year project period. Applicants may propose activities within a single strategy or multiple strategies within each component. Applicants must clearly specify the strategies they plan to support and the activities within each strategy they plan to implement. Strategies not outlined in the initial application cannot be added to work plans in subsequent years of the award. Component 3 is designed to provide the ability for DHQP to assist countries in responding to identified outbreaks or public health emergencies. Please review the detailed description provided in the funding opportunity regarding the designation of a public health emergency. This information begins on page 21 of the funding opportunity document. If you apply for component 3, an overarching work plan and budget for activities is required during the initial application. This component is not pathogen specific and should be flexible and adaptable to any designated public health emergency. IPC strategies and activities may be quite broadly defined, but should include activities leveraging epidemiologic support and respond to a public health emergency. You may want to utilize your experience in responding to the current pandemic as a guide or model for broad activities needed for this component. Funds will only be available if a public health emergency is declared per the U.S. Health and Human Services guidelines. Specific work plans and budgets will be requested at the time of any declared emergency. Please note, funds for component 3 will only be considered if the application is accepted and funded under either component 1, detect and respond to infectious disease threats in healthcare facilities, or component 2, improve capacity to detect and monitor emerging antimicrobial resistance. And as always, award amounts are dependent on availability of funds. Next slide. And as a reminder, all participants are muted. And if you have any questions, please enter them in the chat section. And if you joined late, please remember to put your name and organization in the chat box as well.
Good morning, everybody. I'm going to walk through the strategies that are included in this funding opportunity. Of course, applicants should carefully review each of the components and the strategies and identified activities within the NOFO. Applicants should decide which components they're interested in applying to and prepare a detailed work plan to support the specific strategies and activities that they're interested in applying to within that component. Component 1 is detect and respond to infectious disease threats in healthcare facilities. There are 2 strategies within this component: preventing transmission of infections in healthcare facilities and detecting and responding to emerging antimicrobial resistance in healthcare facilities. Next slide. Activities in component 1, strategy 1, preventing transmission of infections in healthcare facilities, should be implemented in a network of at least 3 hospitals in a country or countries outside of the United States. The proposed network will be part of a CDC organized global network focusing on harmonized healthcare associated infection data collection that is linked to evidence-based and data-driven healthcare associated infection prevention efforts. Next slide. Activities in component 1, strategy 2, detecting and responding to emerging antimicrobial resistance in healthcare facilities, should be implemented in a network of at least 3 hospitals and at least 1 reference laboratory within a country or countries outside of the United States. The proposed network will be part of a CDC organized global network focusing on the rapid identification, confirmation, response to, and containment of emerging antimicrobial resistance in healthcare settings. Next slide. Applicants to component 1 must submit letters of support from all hospitals, reference laboratories, and partners providing additional infection prevention and control support to their proposed network hospitals. These letters should describe the hospital, reference laboratory, or IPC partner's ability to meet specifications described in the organizational capacity of recipients to implement the approach section of the NOFO. Letters of support are optional for components 2 and 3. Next slide. Component 2, improve capacity to detect and monitor emerging antimicrobial resistance, contains 5 strategies: assessing antimicrobial resistance in healthcare settings, enteric pathogens, fungal pathogens, invasive bacterial and respiratory pathogens, and Neisseria gonorrhea. Next slide. Activities in Component 2, Strategy 1, assess antimicrobial resistance at the interface of healthcare and community settings outside of the United States. They may be performed within or outside of an existing network of healthcare facilities or community sites as appropriate. Prioritized activities include designing and implementing projects to inform, implement, or evaluate AMR prevention and control strategies in healthcare settings, designing and implementing projects to improve the monitoring of emerging antimicrobial resistance in healthcare settings, and to assess the potential impact of environmental and community risk factors on AMR infections in healthcare settings. Next slide. Activities in Component 2, Strategy 2, assess antimicrobial resistance in enteric pathogens outside of the United States. Prioritized activities include building whole genome sequencing, or WGS, capacity among PulseNet international participants, and building or enhancing capacity to isolate, identify, and conduct antimicrobial susceptibility testing, or WGS, for enteric and diarrheal infections, to measure exposure risk from potential sources, and to implement or evaluate effectiveness of conventional and non-conventional treatments and prevention strategies. Prioritized countries and regions are described in the text of the NOFO. Next slide. Activities in Component 2, Strategy 3, assess antimicrobial resistance in fungal pathogens outside of the United States. Prioritized activities include increasing support and capabilities for the identification, surveillance of, and response to known and emerging antimicrobial resistance threats, for example, Candida auris and azole-resistant aspergillus. Again, additional information and prioritized countries and regions are described in the NOFO text. Next slide. Activities in Component 2, Strategy 4, assess AMR in invasive bacterial and respiratory pathogens outside of the United States. Prioritized activities include building or enhancing bacterial culture capacity, molecular AMR testing capacity, or WGS capacity in sites conducting surveillance for meningitis, strep pneumoniae, Group B strep, or Group A strep, enhancing Bordetella pertussis lab-based surveillance and evaluating macrolide resistance in nasopharyngeal specimens of patients testing positive for pertussis, and using the data generated from improved laboratory or epidemiology capacity to inform, implement, or evaluate vaccine efficacy and improvement and other strategies to prevent the spread of AMR in these pathogens. Prioritized countries and regions are described in the NOFO text. Next slide. Activities in Component 2, Strategy 5, assess antimicrobial resistance in Neisseria gonorrhea outside of the United States. Prioritized activities in this strategy include expanding the Enhanced Gonococcal Antimicrobial Surveillance Program, or EGASP, activities and capabilities in sites where work has already begun, implementing EGASP per established protocols in new regions or countries, and building focused epidemiology, laboratory, and data sharing capacity for tracking the spread of and risk factors for AMR in Mycoplasma genitalium. Again, additional information in prioritized countries and regions are described in the NOFO text. Next slide. Component 3, the rapid response to infectious disease outbreaks or other public health emergencies in healthcare facilities, includes one strategy. This strategy focuses on improving infection prevention and control to prevent transmission of outbreak diseases in healthcare facilities. Prioritized activities include developing outbreak-specific IPC policies, procedures, guidelines, and trainings, identifying and training IPC focal persons responsible for implementing IPC practices at priority healthcare facilities, providing on-site supportive supervision and mentorship to improve the implementation of IPC practices at priority healthcare facilities, improving screening and triage at healthcare facilities to rapidly identify, isolate, and refer suspected cases for treatment, and implementing enhanced surveillance of healthcare workers and inpatients at priority healthcare facilities. Next slide. A high-level overview of all of these strategies and activities is provided in table format as a logic model in the NOFO, with detailed information provided in the outcomes and strategies and activities sections that are immediately below the logic model in the NOFO text. Bolded items in the logic model are of particular interest to CDC. During each funding cycle, recipients will be expected to show progress on the outcomes and the work plan submitted with the application. Progress will be documented in the annual progress report submitted as part of the continuation application each year. Additionally, progress and issues should be discussed with the assigned CDC project officer on a regular basis, but no less than quarterly. Applicants must provide an overall evaluation plan indicating how they plan to monitor and document performance on activities proposed within each component as part of their application. And with that, I'll pass to Sajada to discuss application review processes.
Next slide. All submitted applications will undergo an initial review to determine completeness and if they meet the eligibility requirements to move forward to objective review. Applications must be submitted by the due date, which is June 28th, 2021, by 11:59 p.m. U.S. Eastern Time. Applications must be submitted via the grants.gov website. Registrations with DUNS and SAM.gov must be active in order to complete an application. Updates to these systems can generally take some time, so please ensure to start the update process early. We recommend at least 2 weeks in advance of the due date. To ensure time to resolve any submission issues via grants.gov, please apply as early as possible. Do not wait until the end of the day on June 28th. Extensions to the application deadline will not be granted. Applicants must adhere to the page limits outlined in the funding opportunity document. Job descriptions for key personnel, a maximum of 1 page for each identified key position. For example, you have the principal investigator, project director, and business official. The organizational chart should be 1 page. The capacity statement should be 1 page. The financial management statement should be 1 page. Letters of support, which is required for component 1, but optional for components 2 and 3, a maximum of 15 pages. The project abstract is 1 page, and the project narrative is 20 pages. And please note, those applicants applying to more than 1 component, so say for instance, you're interested in applying to component 1, 2, and 3. In this case, will allow up to 20 pages for each component you're applying to. And we're in the process of amending the NOFO to reflect as such. So in the narrative section, you would have 20 pages for component 1, 20 pages for component 2, and 20 pages for component 3. And a separate narrative is required for each component. Please clearly identify components and strategies within the narrative section. Next slide. Eligible applications will be reviewed and scored by objective reviewers. DHQP staff who will support implementation of this cooperative agreement, including project officers, will not participate in the application review and scoring. Reviewers will read applications and score according to the criteria outlined in the funding opportunity and can be reviewed in the objective review section. Reviewers will provide an overall score for each application and a rank order list will be developed. CDC reserves the right to fund out of rank order in order to align with US government and/or agency prioritized technical areas and activities, ensure maximum coverage of activities geographically, to avoid duplication of activities in other CDC funded mechanisms, and to respond to unforeseen public health emergencies of international concern. Now I will turn it over to Nicole Comic to discuss the eligibility criteria and available funding.
Thank you, Sajada. Eligibility criteria. As listed in the updated Notice of Funding Opportunity, this is an open or unrestricted competition. Applicants may include state, county, city or township, or special district governments, public and state-controlled institutions of higher education, federally recognized Native American tribal governments or other than federally recognized Native American governments, public or Indian housing authorities, nonprofits with or without 501c3 status, private institutions of higher education, for-profit organizations, small businesses, as well as ministries of health or their bona fide agents in countries designated by the World Bank as low or middle income. Bona fide agents are entities that the Ministry of Health or country government have approved to act on their behalf to implement strategies and activities in the country. Bona fide agents applying on behalf of ministries of health will need to provide a letter of support from the Ministry of Health within the country where work is planned. All final awards and amounts are dependent upon availability of funds, and there are no cost sharing or matching requirements with this NOFO. CDC anticipates funding up to 40 applications. First year awards may range from $50,000 to $800,000 US per award for components 1 or 2. There will be 5 annual budget periods within the 5-year project period. Each year, CDC will assess evidence of satisfactory progress by the recipient as documented in required reports. Annual funding is subject to availability of funds. Annual funding will be based on the progress achieved against stated objectives. Unsatisfactory performance will be documented in discussions between the recipient, CDC project officer, and the Office of Grant Services. Improvement action plans will be implemented thereafter. Component 3 is intended to be approved but unfunded. This component would support additional activities needed within a budget period when a disease outbreak or other public health emergency reaches a scale that requires a moderate response. Applicants must submit an itemized budget narrative as part of the organizational capacity of recipients to implement the approach. When developing a budget narrative, applicants must consider whether the proposed budget is reasonable and consistent with the purpose, outcomes, and program strategy outlined in the project narrative. For guidance on completing a detailed budget, please see the budget preparation guidelines at https://www.cdc.gov/grants/preparation-guidance.pdf.
Thank you, Nicole. Now I would like to provide a few reminders. The NOFO was posted on April 27th, 2021, and will remain open for 60 days until the application due date has passed. The application due date is June 28th, 2021, and all applications must be received by 11:59 p.m. US Eastern Time. Applications will not be accepted after the deadline. Letters of intent or LOIs are optional. If you choose to submit one, please do so by May 27th, 2021. All applicants meeting the requirements as outlined in the NOFO will be accepted for review. The project period is targeted to begin on September 30th, 2021. Next slide. Below are a few questions and responses that we've received to date. They can be found via the link below, and we'll put this link in the chat box so you can kind of review some of the questions and answers that we've received to date. Just going through, I won't read them to you. We have a couple questions on ceilings, which is there is no ceiling, and then what it means to be an ABU or approved but unfunded. Next slide. Multiple organizations funded under the same component strategies, and can you support multiple strategies? So we'll leave that slide up for a second so they can see the response. Next slide. And then there are questions about components, key personnel. Sorry, and we'll leave this up for a second. Let me check the chat box to see if we have any questions there. We do. Okay. So let's see, give me 1 second while I pull out some questions from the chat box.
Sure, and so John, this is Paul. I can actually start with some of the
Okay.
simple Q&A if that's okay with you.
Yeah, that's good, great, go ahead.
And I would also invite us to make sure that our colleagues Ben Park and Don Siebert from US CDC are made co-hosts and are able to speak as well. They'll be supporting us in the Q&A.
Give me 1 second, I'll do that.
Sure.
Sorry.
And I can start with a few that came up that I noticed. Also, keep in mind that there are a lot of questions coming in, and some of them we won't be able to respond to immediately today. Like Sujata said, we are going to collect every question that comes in, and there will be a written document that's posted on grants.gov that includes written answers to all questions that come, even ones that we don't answer live today. So a few questions that I had made notes of, but let me scroll back to in the chat. Just to be clear, there's a question about whether an applicant can apply for all 3 components. Yes, absolutely. Applicants may apply for all 3 components. Please keep in mind that an applicant cannot apply to component 3 alone. An applicant must apply to either one of component 1 or component 2. They may apply for both component 1 or 2. They could apply for components 1, 2, and 3. They just cannot apply for component 3 alone. Another question, 918, I see one about monitoring and evaluation. So I just wanted to cite a few places in the NOFO where applicants can go to look at information about outcomes and M&E strategies. There's an explicit section in the NOFO about outcomes for each of the strategies. Short-term, intermediate, and long-term outcomes are listed in the logic model and also are bulleted out in a separate section. Those are the outcomes that CDC is interested in monitoring. We don't define indicators per se, but applicants should use that to guide their proposal. There's also a section on the applicant's monitoring and evaluation plan. One of the categories that applicants will be reviewed on is the applicant's evaluation and performance management plan. And that starts on page 23 of the NOFO. Where we talk a little bit about how the applicant should tell us about their plans for monitoring and evaluation. I'll also mention that applicants who receive awards would then work with CDC, the project teams, to develop a more detailed M&E plan over the course of the first 6 months of the award, I believe. And then we work collaboratively to develop that. I see a question about and the enteric pathogens in strategy 2 at 914 from Doug that I'll defer to my colleague Don Siebert on. Don is in CDC's antimicrobial resistance coordination strategy unit at CDC and is leading a lot of our work on component 2. Don, there's a question about AMR and enteric pathogens and whether or not that includes parasites, and I'll let you take that one.
Thanks, Paul. Hi, everyone. No, the enterics that we're focused on and looking at are bacterial enterics, Salmonella, Campylobacter. And I think the best way to direct individuals is there are pathogens that are named in the NOFO, and our focus is bacterial and fungal pathogens from our space in component 2, activities 2 through 5. And also the CDC 2019 AR threats report is a good place to go to see the top priority pathogens that CDC follows as far as antimicrobial resistance for bacterial and fungal pathogens. Thank you.
Thanks, Don. I'll continue with a few more kind of quick hitter questions. There's a question about component 1. Will applicants be expected to demonstrate all strategies under component 1? For component 1, applicants are able to propose a network to support strategy 1 or strategy 2 or both strategies. So you're not required to address all strategies. You can choose one of the 2 strategies, but you are able to propose activities for both strategies. Just please make that clear in your application. At 9:25, the last question I'll take right now before I look at some more that have come in asks about letters of intent. And I do want to make sure that we're clear about letters of intent and letters of support. As Sujata mentioned, there's an option for a potential applicant to submit a letter of intent, which just lets CDC know that the organization is interested in submitting an application. That is not required, that's optional. It really helps us at CDC plan for the review process to have an idea of how many applications we should be expecting, knowing that we will get more than that, but it helps us gauge the interest out there as we organize our reviews. Letters of support for component 1 are required. So again, we're talking about setting up these networks of hospitals and laboratories. So applicants to component 1 must submit letters of support as part of their application package from all of the hospitals, laboratories, and infection control partners that they plan to work with that discusses the hospital, laboratory, or partner's capacity to meet the standards that are specified in the organizational capacity section of the NOFO. Letters of support from these facilities are required for component 1. They are optional for components 2 and 3. Those are the ones I put together for some responses. I'll go back into the chat and look for some more. I actually will pass to Dr. Ben Park just for any words or questions that he'd like to address. Dr. Park is the chief of the International Infection Control Program in the Division of Healthcare Quality Promotion here at CDC, and is really spearheading our activities for components 1 and 3. Ben, anything you'd like to add for now?
I think I'd just like to say thank you all for joining. It's really exciting to see all of the participants that have logged on today. It's also amazing to see the level of engagement with the smart questions that are coming into the chat. And I know that there are a lot of them, and we're going to do our best to try to answer the questions, because I think it really shows that there's been some thought into the application, and we're really excited to have a lot of people that are very interested in submitting applications for this. So we're very excited to see this level of enthusiasm, and we're very excited to issue this notice of funding opportunity. And I think overall, we're very excited to get started with this work. I think it's going to be work that will be very well received and will be very important for the future of detection response to healthcare. As everyone knows, currently we're in the middle of a terrible pandemic that's affecting many countries disproportionately. We hope that this NOFO will be one step towards detecting and responding and making healthcare systems safer, not only to COVID-19, but also to the threat of antimicrobial resistance, which we are seeing as being a continued threat and potentially even being made worse during the pandemic. So we think that this NOFO is very timely. We think it's very important, and we think it's going to potentially make a tremendous amount of impact globally. Back over to you, Paul.
Thanks, Ben. And I think there are a few questions coming in about just countries and regions and priorities. So one thing that we should make clear up front is that this NOFO is exclusively funding activities outside of the United States. So there's one question about a network that would be created that would only include hospitals within the United States. That would not be responsive to the NOFO. We are looking for implementing activities entirely outside of the United States for all 3 components. So we'll just making that clear. In component 2, you notice in the NOFO that there are particular priority countries that have been identified, or regions, by various CDC colleagues who are supporting the work on this NOFO. We have not provided a list of priority countries for component 1. Again, this is to be done in settings outside of the United States. The work that the International Infection Control Program at CDC does tend to focus on low and middle income countries, particularly looking at Latin America, South America, Sub-Saharan Africa, Southeast Asia, South Asia, and Eastern Europe and Central Asia. Those are the types of places where we do tend to work, but we do not have any limitations on the countries that you could propose in the application. But CDC does tend to work in these parts of the world. So in component 2, there's a little bit more prescription about the particular regions of focus or countries of focus. For component 1, we don't provide that guidance, but we anticipate that we would be doing some of that work in countries where CDC already does tend to work. There are a few questions about component 2 strategy 5, which is the Neisseria gonorrhea component. And I will actually see if Dawn Siebert is interested in addressing those. Dawn, there's some questions around 930 about EGAF support being done with WHO, support new sites, and then a separate one about testing for AMR surveillance in gonorrhea. Is phenotypic susceptibility testing adequate? So not sure if you wanted to respond to some of the questions about EGASP.
Thanks, Paul. So I want to be careful not to go beyond the detail that is in the NOFO. As everyone can see, it is not strict and prohibitive and prescriptive. So that work is open for applicants to suggest how they will go about that work for EGASP. And yes, CDC recognizes that there's a lot of work going on with WHO. There are established protocols already. And I think that is the main place to focus applicants, is that this is not reinventing any wheel. The idea is the expansion of the existing EGASP protocol and the work that's being done to reach areas where it has not been yet established. And that is why some countries and regions are named. And so I think, I probably would like to leave it at that. I think that whole genome sequencing and phenotypic testing was named in there. But again, I think the best place to send applicants for EGASP is to be paying attention to the existing protocols, because that is the idea, is to establish what already exists, but to expand that, strengthen that, and support it where it already may exist and where it isn't and where it needs to be set up. Thanks.
Great, thanks, Dawn. Actually, Dawn and Ben, I may ask you to weigh in on this question from Mike Lynn as well. Does the NOFO cover activities focused on antimicrobial resistance in post-acute care, non-hospital facilities, such as nursing homes? And then maybe that may vary for components 1 and 2, but I would pass to you guys for thoughts on that.
Yeah, this is Ben. It's a great question. The intent of the NOFO was designed for acute care facilities. However, I don't believe that the language of the NOFO is strictly restricting it to acute care facilities, and certainly other types of facilities could be included, provided that there's a demonstrated need in terms of antimicrobial resistance burden and the need for containment in those types of facilities.
Thanks, Ben. Dawn, anything to add? Sorry.
No, nothing to add to that one. Thanks.
Great. Yeah, thanks. Okay, Sajada, maybe I'll pass to you and see if there are additional questions that you had penciled down for responses.
I see one here, and this is a common question. So it's really hard to answer about the average budget per year. I think we've got it slated as 800K, and I think there's a question here: is that per component per country? No, not necessarily. Can we increase the budget funding request if we cover multiple countries, regions in one application? I will say this about the budget. It's just not possible to approximate the amount of each award without knowing the actual number of applicants. So it's really hard to do. the amount could change depending on the number of applicants for the award and the amount of overall funding available. I think recipients should use discretion when building their budget proposals, demonstrate the need for such costs. So for example, if you're responding with multiple countries, your request may be higher than someone responding with one country. Assure the cost align with the project activities and they're reasonable, allocable, and allowable. And I think you're fine. I think we see the 800 for component 1 around that average amount, and then possibly a little less, maybe around the same amount for component 2, depending on the number of countries you're actually writing your application to.
I think just to reinforce something that Sujata said, which I think is crucial to think about, is that we understand that larger networks that involve more countries or more hospitals or more regions, et cetera, those types of networks will be more expensive to operate. And certainly we understand that. And so as Sujata mentioned, it's important that those types of budgets are justified as you prepare them, so that we can take a look at that and fund awardees in a way that makes sense.
Great, thanks Ben and Sujata for that one. Dawn, I'll pass to you about a question about choosing strategies within component 2.
Thanks, Paul. Yep, so there's a question. There are a lot of strategies, as you can see, listed in component 2. That is to cover the breadth of the work that we do and our subject matter experts do at CDC across the antimicrobial resistant pathogens. And so, no, you do not have to apply for all of the strategies across all of those pathogens. That is for our applicants to look and see that breadth of work that we're looking for and to identify your strengths or the work that you're interested in or work you may have already begun, to look at those and choose. You can choose more than one, but that is up to you. And you do not have to choose all of them by any means. So pick what is of interest and strength to you and focus on that across all of those pathogens across the One Health spectrum that we have listed there. So how many you apply to is up to you, but it can just be one strategy within component 2. Thank you.
Thanks, Dawn. And while we're talking about component 2, there are a few other questions that I could pose to you. There's one question about a site for component 2. Can an applicant propose a study or a project where there are 1 or 2 sites in the United States, but a majority of sites outside of the United States? And I would kind of preface that by saying that I think that having a coordinating body in the United States, like an applicant who's applying from a university in the United States, for example, is certainly able to be funded as the coordinator of all of the activities that are happening under the award. But in terms of implementing activities, I think that we are expecting that to happen exclusively outside of the United States. But Dawn, forgive me if I'm speaking out of turn.
No, actually, Paul, you got it right. That was a great answer. So yes, individuals in the U.S. As coordinators and applicants to do that work outside of the U.S. is absolutely acceptable. But this funding support should not be supporting work within the U.S. We cover that under different mechanisms and other spaces. So this work should be outside of the U.S. for what the funding goes to. For support for individuals who are working outside in other countries, outside of the U.S., they can be from the U.S., but the work should not be within facilities or hospitals or looks at pathogens within the U.S. Hopefully that's clear.
If I could also make one other point about that, is that I think there could be instances where, for example, a U.S. institution would like to perform additional characterization of isolates that might have been collected or might have been initially tested and in fact done most of their testing abroad. And I think that this is okay. So when we use the word exclusively, we're talking about the vast majority of the work that needs to be done and the vast majority of the prevention work that would need to be done as well. So I think it is possible, and correct me if I'm wrong, but it is possible to have additional, sub studies or sub characterizational analyses that would be done in the United States per the applicant's discretion.
Great. Thanks,
Yeah,
Ben.
Ben, I do. I agree with you, Ben. But it would be on like pathogens and specimens and isolates that were collected outside of the U.S. That's right. What we're getting at. Yep. Thanks.
Yep. And then Don, just along those lines, there's one last question for the moment for component 2 that's asking about strategy 2, which is AMR and enteric pathogens, and whether or not the activities proposed are limited to the sites discussed in the PulseNet network. And again, I think to Don's earlier point, the information in the NOFO is the extent of the information. I think it's pretty clear. But Don, not sure if you have anything else to add about the priority countries for strategy 2 and how it connects to PulseNet.
Right. So no, I think that actually can and is meant to have a broader interpretation. For PulseNet specifically, our subject matter experts did want to focus and name some important countries and regions and areas where PulseNet International, may have been discussing and looking, and there has been interest on the CDC side to be expanding into those areas, but acknowledging there is other enteric work that is also listed under strategy 2. And so it is not just the suggested areas or regions that are discussed for PulseNet. That is not to contain all of that enteric work that is described within strategy 2. So that can be much broader per applicant interest. Thanks.
Great. Thanks, Don. Ben, I want to pass a question about component 1 to you. So again, component 1 is really building this global network for detection and response in healthcare. There's a question about whether or not project funds can be used to help identified networks meet some of the infrastructure and technology criteria that need to be met to be selected as part of a network.
There's no limitation on what the funds can be used for in terms of meeting those technological criteria. So I think an example of that could be, support for laboratory for either purchasing reagents or even purchasing machines that could be used for this purpose. And certainly those things could be allowable. I think it's going to be important in the application, as you heard in the application, and as you heard in the webinar today, that it's important to demonstrate that capacity already exists, so that if there's a lot of funding that needs to go towards the additional development of capacity, then this would be obviously one area where it would not be demonstrating that the sufficient capacity exists already. So I think applicants should understand that. But certainly, if it's a reasonable amount that can be used for some things around to kind of bolster existing capacity, I think certainly those would be things that would be entertained.
Right. Yeah, I would echo Ben's point about the specifications that are provided in the organizational capacity to implement the approach section for component 1. Applicants will be evaluated based on how well the hospitals that they propose are able to meet those standards. There is a certain threshold that hospitals would need to meet to be competitive in the application process. There's another question about letters of support, which are required for component 1, optional for components 2 and 3. Does CDC encourage letters of support from respective government agencies? You'll notice in the text of the NOFO that letters of support are only required in component 1 for the proposed hospitals, laboratories, and IPC support partners. So a letter of support from a government agency, a Ministry of Health, for example, is not required, but would be welcome to be submitted as part of the letters of support package, noting that that cannot exceed 15 pages, I believe. Sujata, any other questions that you wanted to address?
I'm still scrolling through. I think there was one here, and maybe you can take this one. How is research defined in the NOFO? Some words and activities in component 2, assessing risk factors, examining potential relationships, lend themselves to interpretation as research. I mean, I would say that this is a non-research COAG, so there is no research that's to happen in this COAG. I don't know if you had anything to add, Paul.
I don't. I think again, it's a non-research COAG. I think there are definitions of public health research out there. I think it will just depend on what's proposed. I think that we attempted to frame all of the suggested activities within the strategies and activities as non-research activities, things like evaluation, surveillance, what have you. But correct, this is research activities will not be funded.
There's a question here about maximum number of healthcare facilities, which could be included. And I think this speaks also to, there are some general questions about the shape and size and scope of the networks for component 1. There is no maximum number of healthcare facilities that can be included. There is a minimum, however, as Paul mentioned, that minimum is 3. So I think it's, and there's no limitation on countries. These networks, again, as Paul mentioned earlier, these networks may be contained in one country, in one subnational district or province. They may also extend beyond countries. They may be multiple countries and potentially even multiple regions. So there is no limitation on that.
Don, want to make sure that there's nothing else that you had noticed on component 2 to address?
I don't think so. I'm seeing one come in right now. Is the whole genome sequencing in component 2 strategy 2 limited to those within PulseNet? I don't think we already answered that. So no, they'll look at whole genome sequencing and the potential to use whole genome sequencing for enteric pathogens, I think would fit appropriately within strategy 2 and the proposal that an applicant would put forward. So, whole genome sequencing is an option. We use it across CDC for work. So there's no restriction on when whole genome sequencing should or should not be proposed, if I understand that question correctly. Thanks.
I think there are a few questions about component 3, and forgive me scrolling through all these are really good questions. It's just hard to kind of scroll through and find all of them. So component 3, there is a question about WASH, like would improving health facility infrastructure, improving WASH be eligible as part of the emergency response component? I would say that in the NOFO, we provide some guidance about the types of activities that we would expect to see as part of component 3 during an outbreak response, focusing on infection prevention and control. These do focus on developing policies, training, supporting IPC focal persons at hospital, working on things like rapid identification and referral of patients with these diseases for care. I think that WASH in health facilities is a little difficult. There are some funding restrictions on doing construction at health facilities. I think that really working on WASH infrastructure is not a priority of this NOFO, but we do understand there may be some WASH improvements that would be required as part of making a health facility ready to respond to an outbreak. Things like improving access to hand hygiene, putting out hand hygiene buckets, for example. That is a wash activity that doesn't involve hard infrastructure at the facility, that would be something that's more acceptable. I mean, for example, standing up triage tents, like that's a change to the infrastructure of the facility that helps in the context of outbreak response. But core wash improvements, renovations is not a priority in this NOFO. You'll see the priorities listed in the specifications for component 3.
Paul, there's a question here I think that's important to clarify about, the question is around component 1, does CDC provide guidance around HAI definitions and detection methods? I think it's important to clarify that this is a cooperative agreement, this notice of funding opportunity. And with cooperative agreements, there will be an expectation for technical collaboration between CDC and the funded partners. So things like HAI definitions, or for component 1, strategy 1, for component 1, strategy 2 around AMR detection and containment, these things will have an expectation for technical collaboration with CDC. And many of these approaches, definitions, et cetera, will be discussed together with our partners from between CDC and the technical and the awardees of the cooperative agreement. So I think it's important to clarify that there's an expectation of collaboration.
Yeah, absolutely. Thanks, Ben. There's a quick question about whether or not this webinar will be posted on the website. Yes, absolutely. The webinar will be posted on the website. There is an email address where you can send additional questions. There's FAQs posted on the website as well. So please do refer to the website for this recording. A few other questions about pathogens in the context of component 2. There's one question, Dawn, about the fungal strategy and whether C. gattii is a priority. There's a question about strategy 5, where M. genitalium is specified, but are other STIs to be considered. I think, Dawn, that I'll answer on your behalf and let you weigh in. I think that the pathogens that are specified in the NOFO and the activities that are specified in the NOFO are examples of the types of activities that the disease programs would prefer to focus on, but we'll let you respond as well, and any other additional comments or questions that you'd like to address.
No, that's perfect, Paul. Thank you. And that was the one that I was looking at to address, because there are a few questions, again, as Paul said, across the strategies in component 2 for which pathogens. When the pathogens are named, they are named because they are important focal areas for those groups and the subject matter experts. And the look that needs to be done in CDC fields needs to be tracked. We track them domestically. We see the importance of tracking them and now looking and working with our partners to look globally for those pathogens. So when they are named, it is an indication that those are high priority, specifically for the programs and where they are named within the strategies. And then if you have questions about other pathogens, and I said this earlier, I'll say it again, I think a place to refer is the 2019 CDC AR Threats Report, because that lists the top 18 priorities for CDC and the pathogens that we see are currently the most impactful as far as antimicrobial resistant pathogens for tracking. And so that will help with an indication of, is this pathogen, I don't see it on the list in the NOFO, please refer to the AR Threats Report to help you make those determinations of what are the CDC top priorities for this AMR work under component 2. Thanks.
Great, thanks, Dawn. A question about component 1, again, creating networks that feed into CDC's global network. The question is about a situation where somebody may propose a network of facilities in multiple countries. Is the applicant expected to constitute a network across the facilities across the different countries, or only link the facilities in each proposed country to the CDC global network of networks? I'll take a first stab at this, and Ben may want to weigh in as well. I think our vision for the networks that are funded for this NOFO is that the applicant would really serve as the network coordinator who's responsible for creating a cohesive network of facilities under their award. So if an applicant proposed a network of 2 hospitals in each of 4 countries for a total network of 8 hospitals across 4 countries, we would want the awardee, the recipient, to really treat that as a network of facilities and coordinate the activities of those facilities. And then the network coordinator, the recipient, would really be the interface with the CDC global network, providing feedback up to CDC, collaborating with CDC, and then helping us implement CDC priority activities in the network of hospitals across the 4 different countries. Ben, anything to add to that in terms of multi-country networks?
No, I think that's absolutely right. I think that for a multi-country network, again, we expect one PI for the network, whether or not that's in one country or many countries. I would just add that for a network of multiple countries, there is the consideration of the complexity in dealing with government. And I think we had talked here before about letters of support from the government agencies in individual countries. Of course, to remind everyone that those are not required, but they are encouraged. And so networks that span multiple countries will just have additional complexities regarding multiple coordination with multiple governments, if that's something that is to be added to the application.
Great, thanks, Ben. I'll flag that there are questions coming in about the mechanics of applying on grants.gov and how applications for multiple components should work. Sujata, I mean, I'll let you speak to some of that, but I think some of those questions are actually better for us to provide in writing on the website more than kind of answering on the fly, but would defer to you.
I think most of them have been answered on the website, but say, for instance, here's one. Page 20 of the NOFO states a separate application must be submitted for each component. Will applicants be able to submit 3 separate applications on the grants.gov portal, or is it the intention that separate applications will be submitted together in one package? Correct for the latter. It is the intention that separate applications will be submitted together. So say you're interested in applying for component 1, 2, and 3. You're going to develop separate proposals for each component, but they will be submitted all together in one application on grants.gov. Nicole, if you're still on, please confirm that that's correct.
Hi, Sujata, this is Nicole, and yes, that is correct.
Thank you.
A question just came in about applicants for if you apply to both component 1 and 2, is it possible that only one could be funded? Yes, absolutely. I think that the review process will happen component by component. It is entirely possible that an applicant may score well for component 1 and score not as well for component 2. I also think that, as Ben mentioned, we do have flexibilities for funding out of rank order, depending on geographic diversity, the types of activities within the NOFO that we're trying to cover. All of those details are specified in the NOFO itself. So yes, it is possible that if you apply for all 3 components, you would only be funded for a subset of them. I think that covers a lot of the questions that are easy to address on the phone. Again, I do think that there will be some written questions that we'll have to respond to. Sujata, are there other ones that you pick up or any other?
Yeah, I have one or two more for Nicole. A question from Sophie Ablott. Sorry if I missed the answer, but are private companies eligible? And Nicole, I think you covered this as well, but if you'd like to provide a response, that'd be great.
I'm sorry, Sujata, I had another call come through. Do you mind repeating that?
Sure. The question is, sorry if I missed the answer, but are private companies eligible?
So this is a notice of funding opportunity that is available to organizations, and the private companies, it would depend on their status. So if you can explain, and you can send us a separate email if that is possible, so that we can address that and we can make sure that we publish the response on grants.gov immediately after the webinar.
Perfect, thank you.
Thank you.
A few other kind of quick clarification questions about how networks or projects and the other components could be structured. There are several questions about, is it possible for an applicant to propose a principal investigator that's in a different country than where the activities are happening? Yes, I think that's fine. I'm assuming there's a good relationship between the principal investigator and the project sites. That would be acceptable. I'll give right, and then Lois, actually, I meant to respond to your question too about public and private hospitals for component 1 and for component 2 for that matter. There are no restrictions on the types of hospitals that could be proposed. But I think public and private hospitals would be eligible under this NOFO. Ben and Dawn, maybe I'll let you guys see if there are any last questions that you wanted to address, and then the rest we can address in the written comments on grants.gov.
I'm scrolling through, and I think most of them have been covered. There might be some that I'm missing, in which case we can, as Paul mentioned, provide those on the website. But yeah, I don't see anything additional, but nothing's sticking out to me right now.
Here's one last question.
Dawn,
Oh, go ahead. Sorry. Go ahead, Dawn.
I'm sorry. I saw one come through. It got buried quickly. Let me. It asked about. Oh, right here. The NOFO covers human health and not animal health factors. Please clarify. So. We are the Centers for Disease Control and Prevention. As everyone knows, our focus is human health. So that is why I talked about the pathogens, and the focus are those pathogens that affect humans and human illness and health and safety. But you'll see within, so we're not looking at animal health pathogens. We're focusing on human health pathogens. But you will notice in component 2 across strategies 2 specifically, there is a lot of work that's mentioned in there because it does cover the enteric pathogens. So that is going to be, it affects also and includes food animals, interaction with animals, that would be more considered pets. There's water written in there for environmental coverage. So we are, again, looking across the One Health spectrum with a focus on pathogens that affect human health. So hopefully that helps to clarify the angle and the space that we're looking at. So there is One Health coverage within some of the strategies in that regard. But again, our focus is on the human health pathogens. Thanks.
There's one question that just came in recently, just to clarify if the prime applicant can be in the US as long as the work is being done outside the US. And we've covered this already, but I just want to reemphasize, since it may not have been clear to everyone, that yes, this is acceptable.
Correct. The next one, will there be an amendment to the NOFO, and what is the expected timeline for amendment release and or written response to questions? Yes, there will be an amendment to the NOFO. The expected timeline for the amendment is probably by the end of the week, and or written response to questions. The questions, I would look for those to be posted by Monday of next week, because we have another call on Thursday, and we'd like to combine those into one. Can an organization submit multiple separate applications? Again, if you're applying to multiple components, you can draft separate proposals, but they should all be submitted as one application. And then what about key personnel participating in more than one application? You can have key personnel participating. I guess you mean I would assume you mean in different components, but maybe I need clarity. So Abel, Abera, if you can clarify in the chat box, that'd be great. But key personnel can work on different, I guess if you were funded for multiple projects, they can work on different ones. You would just need to, I guess, outline the level of effort.
I think while we're waiting for potential response to that, Sujat, I think a really interesting and important question came in just now about component 1 and data sharing, which we make explicitly clear in the NOFO that if you propose activities within component 1, either strategy and component 1, where you're part of the CDC global network, we do anticipate that there will be a data sharing expectation with CDC. And that's something that is going to be important to be aware of upfront. We want that openness to be there from the beginning of these applications. I'll ask Ben if he wants to weigh in anything else on data sharing. The question really gets into, will the data be shared with CDC or across different network sites? What will that shared data be used for? I think the technical vision is evolving a bit, but happy to hear you respond to the data sharing question as well.
Sure, I think this is a critical question. I'm glad that someone brought it up. Yes, absolutely, there is an expectation to share data as appropriate with many different levels, not just with CDC, but with the other members of the individual networks and also across networks. However, the data that are shared will not be the same. And of course, those data we understand are subject to sensitivities around the data within a network, across networks, within countries, across regions, and globally. So we fully understand that there are sensitivities around data, but we do also want to make sure that there is an expectation that the data will be shared and will be shared as appropriate. One of the powerful things about developing this network of networks is actually the sharing of data, and is actually the ability to understand what's happening across many different facilities in many different regions and countries. So the exact types of data that will be shared and the exact and how they will be shared is in development, and it's something that we will undertake together with the awardees because we understand, of course, that there may be differing levels of comfort with sharing data. But nonetheless, there is certainly an expectation around data sharing. And so I would consider that as you develop your networks or as you develop your partnerships, that there will be some level of data sharing, and that there should be some comfort in that.
And I think Ben was speaking very much towards component 1, but Dawn will invite you to respond about data sharing for component 2 as well.
Absolutely, thanks, Paul. Yes, and I will echo what Ben and Paul have said. That does go for component 2 as well. The idea of looking at the antimicrobial resistant pathogens and where the issues lie does require the sharing of data. It's collaboration and working with CDC and then working amongst partners through the applicants. So there does need to be that comfort with sharing those data within that space, and to be able to use that information for potential alerts and looking at serious concerns with resistance. So again, we look at that in the most confidential way that we can and the secure way that we can. It is not about looking and pointing a finger or throwing somebody out as an issue in public and things like that. So we take the utmost considerations for how the data can be secure and confidential, yet still shared at the level that's needed for action and response. And so that individuals who can deal with the situations are alerted to it. So again, as Ben said, there is a level of comfort that needs to be with the data sharing, because action does need to be taken from these data. Thanks.
So I think Raven is posting the links to the website and the email address. You also see that on the screen. And I think that's a place where you can get answers outside of the webinar. Again, we'll be posting the recording of the webinar on that website as well, along with the FAQs that are regularly updated. And then the written questions from today would go on to grants.gov. So John, I think we covered most of what we wanted to cover in the Q&A, unless there's anything else you'd like to add, and otherwise I'll leave it to you to wrap.
Yeah, I think those questions that we didn't cover, they'll definitely be answered. Look for those on the website and grants.gov. But yeah, nothing else to add. On this screen, you should see NOFO points of contact, program office, and the emails for myself and Paul, and as well as the contact information for Nicole Comic. We really appreciate you guys joining us today, and I hope we've answered the bulk of your questions, and those, as I said, that we didn't answer will be posted online. So thank you again for joining us, and we'll give you back about roughly 40 some odd minutes back. Thank you again. We appreciate it.